While we wait for the PowerPoint to load, could I ask everyone to introduce themselves very briefly? So I'm Charlotte from Leukemia Care. I'm the Patient Advocacy Manager here. Clare Harrison, would you mind going next?
I don't mind going next, just have difficulty finding the unmute button. Hello everyone, my name's Clare Harrison. I'm a haematologist at Guy's and St Thomas's Hospital.
Thank you. And the other Claire, apologies for referring to you as such.
I'm one of the clinical nurse specialists at Guy's Hospital.
Thank you, Claire. And Adam?
Hi, my name's Adam Mead. I'm a haematologist in Oxford.
Wonderful, thank you. And Donal?
Hi, my name is Donal McLornan. I'm a haematologist in Guy's and St Thomas's.
Thank you. And Joe is still connecting to audio by the looks of it, but we will also be joined by Jo Peplow, who's the Patient Services Manager here at Leukemia Care, and she'll be assisting me in asking the questions. So I've now got everything working smoothly, hopefully, and we can crack on. So the aim of today is to give you an update on our last webinar, following our last webinar, I should say, which was approximately 3 weeks ago, on the potential impact or experience of MPN patients during the COVID-19 pandemic. So I'm going to start briefly by going over some of what I said before and a little bit of a recap of the last webinar, and then I'll pass to our clinical panelists who will give a little bit of an overview each of their perspective and some more detail on what I'm going to say, and then we'll have plenty of time left for questions and answers. So just to recap, the general government guidance for those affected by blood cancers was issued approximately the 20th of March. I change the date every time I say it, but it was approximately the 20th March. And the advice was that people with blood cancers of the blood and bone marrow, including leukemia and such, were likely to be at extra high risk of severe COVID illness if they were to catch it, and therefore they should start a process known as shielding. And the aim of this advice was to take a cautious approach. I mean, indeed, now we don't know much about COVID, but certainly back in March, there was very, very little information on this new virus, and therefore the NHS and the government took a cautious approach to who they classified as high risk at the time. So in the last webinar, we sort of talked about a little bit of what this meant for patients and what they should do in response to that guidance. So as I said, that the government guidance says anybody affected by a blood cancer at any stage of treatment should be shielding, and that's what we discussed at the last webinar. There is obviously going to be some people, depending on treatment, depending on age, that will be more at risk than others, but you should speak to your clinical team if you're not sure whether you should be definitely shielding or not. At that time, there was certainly little or no evidence of the effect on patients directly. There have been in the media several papers that possibly suggest that blood cancer patients may be at more risk or may not be at more risk, and I'm sure Adam and Claire can talk about those if there are any questions regarding to those. But in our last webinar, there was certainly no evidence of this. But importantly, Adam also shared a lot of information in our last webinar about the good news coming out about COVID-19, so potential vaccines, potential trials, and I know he's going to give us an update on those again today. And it's always good to reflect on the positive news. I guess a question on a lot of people's lips at the moment is, will this shielding period continue? So it's important to say that the initial 12 weeks of shielding ends on the 30th of June, and we don't know at the moment if that will be extended. There was a little bit of confusion around the announcements last week as to whether the government advising the general public can go out a little bit more, whether that applies to shielded patients or not. And it says deep within the 50-page document that they issued that the shielded patients are not advised to stop shielding at that point, but to continue to do so until the 30th of June or until the government issues further advice. And we just don't know after the 30th of June whether that will be extended at this point. And I think it's important that right now is, if you are shielding, not to stop shielding right now. You hear a lot about it being past the peak of the pandemic and things like that, but I think it's a bit too early, based on government guidance, to make that decision to stop shielding at this point. And please reach out if you need support. I appreciate it's a tough time for those of you who are shielding. So do reach out if you are in need of any support at this time. Just a quick recap on what shielding actually is. The strictest interpretation of the shielding guidance is that you shouldn't leave the home at any time except to attend a medical appointment as advised by your medical team, and that you should also social distance from others that you live with, including using shared spaces at different times and separate dishes and all that sort of thing. And if you don't have a letter, you can still request one if you need one, and you can contact your GP is the best person to contact in the first instance, as they have the ability to issue the letter, but also speak to a haematologist if you're having trouble having that conversation with the GP about whether you should be shielding or not. And in terms of the wider impact of COVID beyond sort of the individuals, obviously a lot of patients were concerned about whether this would have an impact on their treatment and potential change to their treatment. And I know a couple of our clinical colleagues are going to talk about this in more detail, so I won't sort of expand on it too much. But the important thing to note is that urgent cancer treatment is still a priority, and every intervention is being looked at on an individual basis. So if you are asked to have an appointment, or you're asked to have a blood test or anything like that, it's likely that that is because it's essential still. And if you aren't sure whether you should be attending a hospital at this moment in time, please have that conversation with your haematologist, talk about the risks and the benefits, and I'm sure they'd be more than happy to explain their rationale to you. And on that note, I'm going to pass over to Clare Harrison, who will start to give you a bit of an update from her perspective.
Well, thanks very much, Charlotte. Can we have the next slide?
Of course.
Thanks. So I've just got a quick update on, a little bit about biology, and then just reflecting on overlaps. And as we speak to many of you over the telephone, just asking for, what the latest news is. One of the key questions that's been coming up is the issue about the link between COVID-19 and thrombosis. So we've learned quite a lot about the biology of this condition as reflected in this cartoon. We know that it's a viral infection, we know about transmission, etc. But we've also been learning something about the phases of the illness. So let's have a look at the next slide. So what we still know is that most patients will have a very kind of low grade illness. Some patients don't even notice that they're having it, have it at all. But some patients have a phase of the illness as reflected on the right-hand side of the slide, where they have a high level of inflammation. So by that time, mostly the virus has gone, but it's more how the body's immune system is reacting to the virus and the problems that that can cause for patients. So you will have heard this morning, for example, some news about vaccination, and Adam's going to talk about that. But also this morning, some news about some findings from colleagues at Guy's and St Thomas's, actually, about how low levels of certain types of lymphocytes, white cells, are seen in patients with more serious COVID-19 illness, and how that might be tackled. So there's a lot of focus at the moment about the immune system and how that interacts with the virus. And if we turn to the next slide, one of the ways that interacts with the virus and our body kind of responds to the virus can cause problems across the body. And one of those problems is actually thrombosis. So we know about this, and we've known about this for some time, that so-called hyperinflammation or an overactive immune response can trigger problems with blood clots forming. And on this slide, you can see a variety of different blood clots that are seen by patients, inflammation of the heart, inflammation of the arteries. And only recently in young children, a syndrome was also linked to coronavirus infection with a similar kind of features. So of course, for those of us who are interested in MPN and those of you who have this condition, you'll be well aware of the link with your condition and thrombosis. So that has triggered a lot of questions. So we wanted to take the opportunity to try to address that today. Let's take a look at the next slide. So what do we know about coronavirus? If we can move to the next slide, great. Around 30% of critically ill COVID-19 patients have blood clots. So that sounds quite familiar, doesn't it? If you think about MPN patients, about 25 to 30% of patients with MPN may have blood clots during the course of their therapy. Is there any overlap? Well, you would have also heard some coverage on the BBC from Professor Aria and Professor Hunt, both of which from South East London recently, talking about sticky blood. But actually, sticky blood in the context of coronavirus, and often we refer to MPNs, don't we, as sticky blood conditions. Actually, remember that the causology of clots in MPN patients is quite different. It's not after an overwhelming infective period. Most of you are well, you're walking around, you're not on a critical care unit. Generally, if you're stable on your therapy, we will have controlled your risk of blood clotting. And thus far, in the patients that we've seen who have MPN and coronavirus infection, and we were discussing only yesterday with Adam and colleagues how many we've seen across the UK, this has not turned out to be a problem. One final thing to say before I hand over to Donal is that I would be cautious as a patient if I was a patient who's had a serious blood clot in the past, because this might be associated with problems with function of the organ. For example, a blood clot that might affect the liver or the blood supply to the gut may mean that those organs are less able to cope with overwhelming infection. But you are, of course, on protective drugs to protect you from having a clot. So again, you shouldn't be more susceptible to this aspect of coronavirus illness. So I'm now going to hand over to Donal, who's going to talk a bit more about what we're doing in the hospital and how we've adjusted our services, etc.
So good afternoon, everyone. So really over the next few minutes, I want to bring us through sort of what we can all expect, both on the nursing and medical side, and also most importantly for you as the patient, and how we're changing the hospital landscape. Next slide, please. So the options for us, this happened very quickly, as we're all aware, and that meant within many of the hospital systems across the world, we had to very readily adapt our systems for our patients. What we need to do is balance your outpatient or inpatient experience, protect health during this COVID pandemic, but also in parallel, be able to deliver an efficient and holistic MPN service. Attendances for those who have had attendances and necessitated face-to-face appointments, you can see that the outpatient setting has changed dramatically. We have to have social distancing within our departments, and that means that the clinic that many of us have become accustomed to will change. And obviously, I think over the next few months, we'll have guidance from the Department of Health, and that will mold how both the outpatient and inpatient experience will change. Next slide, please. Clearly, for us, we aim to strive to deliver excellence and comprehensive MPN services. There was a halt in clinical trials at the very start of the pandemic. For us as clinicians and nurses, we are now prioritizing trials which we want to open again. And there has been publication from the NIHR, so the UK Research Society, yesterday on guidance for clinicians and nurses about hospital trials. And for those patients who are established on treatments or who may be deferred starting treatments, your individual hospital team will perform a risk-benefit approach on when is the best time for you to start treatment. Next slide, please. So many of you may have experienced on the call, for us as well as clinicians and nurses, it is relatively new, remote consultations. The platforms can range from telephone calls through to video or other Skype-based approaches. This obviously prevents you having to come to a hospital environment. For many, it avoids having to travel into cities or on public transport. It provides a facility for your doctors and nurses to speak to you because you're currently shielding. And also importantly for us, we saw massive changes in our staff who were in the hospital at any one time. At the peak of the pandemic, many haematology nurses and doctors were redeployed to other areas, including intensive care. And it facilitates us working from home where that is needed. We do have to state that where a face-to-face consultation is needed, your team will be able to facilitate that. And importantly, as we change through this process, it's important for us to have feedback from you about creating the most ideal experience. Next slide, please. So that's the focus on remote consultations. As Claire had mentioned in the previous webinar, we had worked very closely with our pharmacists in the hospital and community setting and have been striving to deliver medications to you at home where that is possible. There is ongoing work across many hospitals to facilitate remote blood testing, so meaning that you as the patient do not have to attend the hospital for bloods. That can range from attending your GP practice, if they're currently providing facilities for shielded patients, or mobile blood units where you can have remote testing done. You may know, depending on your hospital, that your staff and clinic location may change, dependent on each individual hospital. And the experience for all of us, including us on the clinical side, will be very different. When you come to hospital, you may see us wearing masks. There can be temperature checks at the door when you're coming in. And often with the consultations, we're wearing some form of personal protective equipment, depending on your local hospital. So that's a very different experience for us all. Next slide, please. So the last two slides I want to share today, and part of my role is stem cell transplant, and that applies to some of us potentially on the call today. So for those of us who are aware, the transplant process is a very complex chain of events. And for us, there are many hurdles across that route. So transplant activity across the United Kingdom slowed down dramatically at the start of the pandemic. That's because both the patient and donor are at risk of infection. The supply chain of cells, often which are coming from abroad, can be interrupted. There may be medication or transfusion products, so red cell or platelet interruption. And many of the transplant clinical studies, just like happened in MPN, were put on hold. But it's very important to know that the transplant teams adapted for each local context. Next slide, please. So for the donors, so those are the patients who are the individuals who are donating the stem cells. Sometimes deferral had to occur because they were actually in a risk category. As of a few weeks ago, every UK centre is now testing and screening donors for COVID-19 and also screening in the follow-up period. Challenges that we're facing are receiving cells from abroad because of lockdown variations across countries and ability to get cells on a specific day. So that means that there was a lot of work through Anthony Nolan about obtaining cells, and there is a cell collection hub now at Heathrow Airport for distribution of cells across the UK. And what your transplant doctors and nurses are doing is facilitating freezing of the cells before the patient will start conditioning. And next slide, please. And that means that when the conditioning starts for the transplantation, we're all content that we have a cell product to infuse back. Clearly, at the start of the pandemic, the numbers of transplants fell. Many centres are now starting to increase activity across the range of transplants. But I think it's important to stress that at present, that's mainly for those with acute and blood disorders, and for many with chronic blood disorders, we're waiting till we're further through the pandemic before starting the transplant process. And obviously that's a balance of risk. Next slide, please. I'd just like to finish before I hand over to Adam. I think we're all together working our way through this, both physicians, nurses, and patients together. I think we're all getting used to these virtual platforms, and I think we'll get much better at that together. Thank you.
You're still muted, Adam.
Great, thanks very much, Donal. The classic mistake to forget to turn off the mute button. So what I want to cover is a little bit of an update about the kind of progress that's being made not in a specific way to MPN patients, but in a global management of the coronavirus. And the first point that I really want to make is you've got to be really careful where you get the information from about this, because there is a lot of information about, not the least from the President of the United States. We go to the next slide. He's, you know, at various different press conferences promoted the use of disinfectant, zinc, heat, light, and is in fact taking zinc supplements and hydroxychloroquine, which remains an unproven treatment and potentially dangerous, as I will come to. So be careful where you get the information from, and definitely don't take any supplements or treatments that you might have heard about that might be that are proposed to be protective against the virus without discussing with your healthcare team. Okay, next slide, please. So, you know, the key thing is not anecdotal data and rumors. What we need is absolute rigorous clinical trial data. And there, I think the networks relating to the NHS and the National Institute of Health Research that Donal mentioned are absolutely crucial. And the efforts that are being made in order to speed up the process are particularly this idea of repurposing drugs. So there are a number of antiviral, anti-malarial, and anti-inflammatory drugs that are already approved for other indications or had been developed, for example, as HIV or Ebola treatments that are now being repurposed and tested in large randomized clinical trials in order to see whether they work against the coronavirus. And typically there are some preclinical data to support the use of these agents. So that's laboratory data that suggests they might be helpful. And then they can go almost straight into quite big clinical trials because there are already approved drugs with a safety track record. And the really incredibly impressive landmark trial in the UK is called the Recovery Trial. And in a space of about 8 weeks or so, this trial has recruited over 10,000 inpatients with coronavirus across over 150 sites, which is an incredible achievement. And we will expect, in fact, over the coming 3 to 4 weeks, preliminary data from some of the drugs being tested as part of that trial. There are trials for patients also on ITU and trials for patients in primary care going alongside that are equally impressive in the way they are recruiting. So I just want to cover a few of the potential treatments that are coming through. Next slide, please. So there are a lot. So this is just a summary slide. I showed a similar slide last time. I don't expect you to see all the details of all the different agents that are being tested. It is more just to convey how much effort is going into this. These are pretty much all available drugs already approved that are being repurposed and tested in good prospective clinical trials, and we're going to get data soon. In fact, for some of them, we've already got data. Next slide, please. So one of the treatments that was got a lot of attention very early on, including from Donald Trump, was hydroxychloroquine, which is an anti-malarial treatment and is also used as an anti-inflammatory treatment. But there's quite a lot of emerging data now that it doesn't work. So there are randomized trial data, as shown on this slide, from multiple different studies showing no benefit of hydroxychloroquine above not receiving hydroxychloroquine in various different healthcare settings. In fact, just today, after I made these slides yesterday, there's a very large study in the Lancet, which isn't a randomized trial, but still a very large study showing that patients treated with hydroxychloroquine with coronavirus were actually at increased risk of death, 35% increased risk of death compared to patients not receiving hydroxychloroquine. So this shouldn't be taken outside the context of a clinical trial. Okay, next slide, please. On to some more promising treatments coming through. So you may have seen in the news the idea of convalescent plasma. So that's the idea that you collect plasma, a bit like donating blood, from patients who have had the coronavirus and recovered, and that plasma contains antibodies that that patient has made, and then you infuse that into patients with active coronavirus infection. Again, through the networks in the NHS, those trials are underway. They're rigorous, prospective, randomized trials, and we should get the answer pretty soon to those data. An alternative approach shown on the left-hand side of this slide is actually you can engineer the antibody. So instead of taking it from patients, you actually work out exactly what the antibody looks like, and you construct that antibody in the laboratory, and then you can infuse the kind of engineered laboratory. And the left-hand slide is taken from a paper from a top journal called Nature Medicine, where researchers have already used sophisticated techniques to identify the antibodies that are made, to purify those, to generate those in the laboratory, and then they showed in various different model systems that those antibodies were highly effective at inactivating the virus, including in animal model systems. And those antibodies will soon be coming to clinical trials. So a huge amount of progress being made there. Next slide, please. In terms of vaccines, I think this is the great hope for getting us out of this coronavirus outbreak situation. And the problem is, typically as shown at the left-hand part of this slide at the top, this is a process that takes many years. And what's been quite remarkable is how this process of developing a new vaccine has been adapted to really massively accelerate the progress. So that, you know, we should be in a position towards the end of the year when we've got viruses that might start being rolled out, dependent on the results of ongoing clinical trials. And I think, again, the UK is at the forefront of this. So the Oxford vaccine has already been given to over 1,000 patients in the UK. The problem is that there probably isn't enough coronavirus around in the UK at the moment for them to get conclusive results. So they're actually taking this vaccine forward into healthcare workers who have a higher incidence of developing the coronavirus infection. But they've now just published some encouraging data, which is shown on the bar chart on the right, showing that the vaccine in animal model systems can be quite effective at protecting against severe pneumonia associated with the coronavirus. And you'll also have heard that the Oxford University and the government have struck a deal with AstraZeneca to make up to 1 billion doses of this vaccine, should it prove encouraging. And the trials are now extending from 18-year-olds to 55-year-olds and going into children, 5 to 18-year-olds, and also into older adults above 55. That was just announced today. Okay, next slide. Thank you. So the other interesting thing that is emerging is that there may be some inherent protections some of us already have against this coronavirus. As many of you may know, the common cold is frequently caused by other types of coronavirus. And there's emerging evidence that some of us may already have some lymphocytes in our system that give us partial protection against this novel coronavirus. And that may help to explain why some patients are getting much milder disease than others. Next slide. Last couple of slides now, just to talk about antiviral therapies. So there's a combination therapy, including a treatment that many MPN patients will know about, interferon, but in this case, interferon 1 beta, combined with this combination of different available antivirus treatments. And the complicated charts at the top essentially show that patients treated with this combination highly statistically significantly cleared the virus more rapidly than those that didn't receive this combination. And that is again getting taken forward into larger trials. Next slide. There's another treatments that you'll have heard about in the news, Remdesivir. Here there's been slightly conflicting data, and it shows why you have to do really big trials. The data on the left was published in a smaller trial of just 200 patients, which did not show benefit of this particular drug. The NIH in the US, in an international study, ran this in over 1,000 patients and showed that this treatment was associated with a 31% faster time to recovery, which was highly statistically significant, a shorter period of time as an inpatient, and emerging data, although not statistically significant at the moment, that it reduced the mortality rate. Next slide, please. And there are also emerging anti-inflammatory treatments coming through. Tocilizumab is showing promise, and there are some trials of the JAK2 inhibitor ruxolitinib and also interferon, as I mentioned. So some of the MPN specific treatments are actually coming through as potential anti-inflammatory treatments to treat patients with more severe disease. Next slide, please. And the final comment is, as Claire had mentioned, there does appear to be an important role for thrombosis and blood clots in the development of the disease. And there is emerging data, not from randomized controlled trials, but there is emerging data suggesting that patients who receive anticoagulation whilst they're an inpatient have better outcomes. So that is a very intensive area for ongoing research. So that's everything I think I wanted to say, and I'll hand back to the leukemia care team. Thank you.
Thank you, Adam and Claire and Donal there. And I think my colleague Jo has now joined us.
Yes, apologies for getting late on to the, I had a few internet issues this afternoon, so apologies for that. Good afternoon, my name's Jo Peplow. I'm the Patient Services Manager here at Leukemia Care. I've been monitoring all the questions. We've had lots of interest, lots coming through, both through Facebook and on the Q&A and chat. And first of all, we seem to be getting a lot still on there about shielding. So some of the things that we've had coming through is about the confusion about who should be shielding and why people are getting different letters. Maybe one of the guys could take that on, Donal?
Yeah, so I think at the very start of the pandemic, when the Department of Health were sending out the letters, there was quite a varied response initially, I think, in the current rush to get letters sent out. I think through Public Health England, I think for our MPN patients who have not received letters, the advice on the website is to contact your general practitioner and also potentially your local haematologist. But normally this is done through your GPs. And from feedback, I know that some people have struggled with that. But there is, on the MPN Voice website, as you know, complete information on the risk groups and how to register.
Okay, thank you for that. Does anybody else want to comment? No? Okay, so leading on from that,
Jo, I think Claire wants to comment.
Sorry, she was coming off, was she? Sorry, Claire. Yeah, carry on.
You may have to struggle with which Claire. Sorry about that. We're used to that in our team. Okay. So I just wanted to, I could just see a few questions popping up about who the letter comes from.
Yeah.
So just wanted to clarify that. So some patients will have had letters direct from their GP. Some will have had letters direct from their hospital. And some will have had letters more centrally generated. I think this has been a problem for MPN patients because this whole thing about blood cancer, not blood cancer, and being rare conditions. So often these letters may well have come from a hospital. And so the format of the letter may be slightly different. That's all I wanted to just add.
Yeah, that's what I was going to lead on. That's fine.
I'll just add a brief comment to say that the kind of the exact phrasing of the shielding advice has been subtly changed in that they now make it clear that it's not a kind of a mandate. It's clearly the patient's choice. So and there's a section on the government website where it makes it clear that while shielding is for your personal protection, I'm reading it off here, it is your choice to decide whether to follow the measures we advise, and you can make that choice together with your your own medical team. And I think that's the overall message, that if you're not sure in your specific case, your own medical team can help you make the decision.
Okay, thank you for that, Adam. Leading on from that, we've started to see in the media recently that maybe shielding could potentially continue. From a clinical perspective, does shielding need to continue, do you think?
Maybe I can comment there with just some reference information. So at Guy's and St Thomas's, we've been swabbing all the patients who've come up to our cancer centre, all the patients coming up to our day unit, and actually all the dialysis patients as well. And these are all shielded patients. It's very interesting to note that actually shielding does seem to be very effective. So way less than 2% of our patients are testing positive. I should say we don't encourage people to come up if they're symptomatic. So these are all asymptomatic folk. I think at the present time, the prevalence of the coronavirus illness is different in different areas of the country, and it will fluctuate from week to week. So I think it's important to continue to shield at the moment, to be more reassured. But I think it's important to continue to be cautious. And if you have chosen to shield strictly or not shield strictly, we see a lot of questions about children going back to school, and that's going to be a pressing issue in the coming weeks. I think it is likely to continue at the moment, and I think you should continue to be cautious, however you have chosen to interpret shielding. I don't know if others want to comment.
I mean, just to add to the benefits of shielding, we've also done a similar process of screening transplant recipients who, by definition, often need to come up to hospital within the first few months after transplant. And again, because of shielding, we've seen a very, very low incidence, a couple of patients who've been COVID positive.
And I would just add that, Claire mentioned during her talk that we discussed yesterday across many of the major centres in the UK that we hadn't seen obviously worrying incidents of severe outcomes associated with MPN. But it's important to remember, because I saw some questions coming through about that. Does that mean that MPN patients don't have to shield? No, because it may be because MPN patients have been shielding that the incidence is low. So I think we need data, we need to learn, we need data, and then we can have a kind of data-driven advice that goes out to people. And you can be assured that we are putting in major efforts to collect those data so that we can give you all much clearer instructions about who really does need to shield. And I think there will be some people that do need to continue, and those where it's probably safer to behave more like the rest of the population and socially distance rather than shield.
Okay, so touching on something that Claire just talked about there, one of the questions we've had through is about children going back to school, and they've asked, should I go back to work, let children go back to school? Maybe Claire Woodley, could you pick that one up for me?
Yeah, hi. So we've had quite a few phone calls about this. The government and the Department of Education have issued schools with guidelines on what they should try and implement, or practices that should try and be done for reintroducing children into school. It's an anxious, unknown territory for us with this. The government are basing their findings of reintroducing reception year 1 and year 6 pupils on the scientific evidence. I think the question arises about when parents are shielding, and what the government kind of said as of this morning was that if your child can understand what is meant by social distancing and can do social distancing, then it is fine for them to go back to school. But as we all know, 4 to 5-year-olds are very difficult to social distance. And in that case, then they're saying there is no expectation for parents to send their children in these circumstances. I think the best thing to do is to actually get in contact with the school that your child attends, speak with family liaison officers, see what processes they are having in place, and discuss with them what the potential risk is for your child in returning.
Thank you, Claire, for that one. Anybody else want to add anything? Okay, so moving on, we've had quite a few questions on the chat as well about vaccines, and the worry seems to be whether or not, because it's live viruses, that would MPN patients actually benefit from a COVID vaccine when they're available? Adam?
There are lots of different vaccine strategies being adopted. The Oxford virus, the vaccine strategy is based on an adenovirus, but it is not a live attenuated vaccine. It's quite a different approach. And my understanding is that that's the type of vaccine that could still be applied even in patients with a degree of immune suppression. But, you know, we need more data, and those trials will be done, and that's what will take the time, because the trials will inevitably initially be done in patients without an underlying diagnosis, and then be expanded to patients with hematological malignancies and related conditions. So we need more data, but there are multiple other trials worldwide using completely different vaccine approaches that are looking equally promising.
Okay, and then leading on from that, we've had a question about when shielding does start to lift, would vulnerable people be a priority, do you think, for a vaccine?
Yes.
Okay, thank you very much. Okay, so the other thing we've had is about, we've got a few questions in here about treatment and whether or not during a pandemic, should you continue to access the treatment for as long as possible? And also leading on from that about the benefits of maybe switching treatment as part of sort of avoiding a hospital.
So I think just to start an answer to that, with regard to treatment, I think we do consider treatments very carefully, and we use treatment primarily to reduce the risk of blood clotting and to keep you in good health and to keep you out of a hospital. So I think it's important where possible to continue your treatment, and that needs a good dialogue with your healthcare team and your family doctor to make sure that you can continue to access treatments and their monitoring. Switching treatment at the present time, again, we would have to weigh up the risks and benefits. Often if we're switching treatment, there's a rationale for it, and it would be weighing up the benefit of that target versus the risk of having slightly more out of control blood count, slight increase in risk of clotting or bleeding, but also the need then to come for a blood test, whether that be in the hospital or elsewhere, depending on where you are. Okay. So very much an individual discussion.
Okay, thank you for that. Maybe I can ask Donal to answer this one. We've got one here about transplants. So someone that's had a transplant, are they especially high risk? How long after a transplant would you say they were still at high risk?
Yeah, so this has been looked at by the European Transplant Society, and also then clearly transplant recipients within the UK fall under the vulnerable group and are currently being shielded. They're particularly at risk because the immune system needs to grow up after transplant. It takes a long time to learn how to fight infections. So that's why vulnerability, particularly within the first 6 months after transplantation, but that could extend up to a year or after. So at present, transplant recipients do fall into the vulnerable group and are shielding.
Okay, anything for anybody else on that one? Thank you. So what is the process if an MPN patient gets COVID? Should they come straight to you first? What's the protocol?
That will vary depending on the site. At our site, you know, we've got a triage service, which is the first port of call for all patients with blood cancers. And, you know, it's important to remember that even though there's still quite a lot of coronavirus about, there's still a lot of other illnesses about too. And as the incidence of the coronavirus decreases, it's really, really, really important for MPN patients and other blood cancer patients that we consider and assess patients carefully as to whether it's likely to be coronavirus, in which case patients will be treated in a certain way, or whether it might be an alternative illness, in which case other investigations and management might be indicated. So the first port of call, at least at our centre, and I think for many centres, will be still the haematology service, and then they will offer you appropriate advice as to the next steps.
Thank you for that. And then we've had a couple of questions on the chat about vitamin D. What's your thoughts on patients taking vitamin D? It's been in the news, I know recently, about people taking this.
So well, maybe I can jump in there.
Yeah,
go ahead, Adam. So a couple of things. Vitamin D is effectively mostly manufactured in your body after exposure to sunlight. So there have been some recommendations that the population take some vitamin D, because actually generally many UK residents are vitamin D deficient because we don't live in a very sunny country, but also at the moment many of us are indoors. There is some anecdotal, that means kind of almost hearsay, if you like, evidence that vitamin D may be important in supporting the immune system in fighting off the virus. And in fact, there are some research studies ongoing. For example, there's one that we've been running through our occupational health at Guy's and St Thomas's, just looking at if we give our frontline workers vitamin D supplementation, does that make any difference? But I don't think there's any evidence for taking more than a standard supplementation of vitamin D, and I don't know what Adam would say to that.
I agree. I mean, one could predict with a lot of different illnesses come through that at some point in time, someone will propose vitamin D as a great new treatment for that particular illness. And in fact, there were many people joking about this with the coronavirus, that vitamin D will truly emerge as the next important treatment. I think, you know, we need data. We need data, rigorous trial data to back it up.
Okay, thank you. Looking at trials, can a patient become a part of the trial? Can they sign up?
So there are a wide range of different trials that are ongoing in the UK, and of course a patient can sign up for a trial if they're eligible, and that would be in several different ways. So for example, I mentioned we're swabbing patients. Soon we may take blood for antibody testing, which will be coming online next week, perhaps. So that would be part of a kind of surveillance study. If you become unwell with coronavirus and you happen to be admitted to hospital, or perhaps even seen in the emergency room or in the acute haematology assessment, you may well be offered the opportunity to take part in a clinical trial. Otherwise, we are collecting data. MPN Voice has put out some data collection. So there are all sorts of different ways of participating in trials in this context.
Thank you for that. Perhaps I can ask this one to you, Charlotte. Someone that's feeling a little bit down, a bit depressed, not feeling good at the moment, what could they do to make them feel better?
Yeah, absolutely. I mean, it's an interesting one, because I've heard from a few patients that they find that obviously shielding and the isolation involved is really tough, and I'm sure a lot of people can relate to that, but also a lot of people perhaps feel as if they're going backwards to a time where they may have had to isolate because of their blood cancer experience, particularly if they've had a transplant. So I think there's two groups of people who perhaps finding it difficult in different ways. Obviously, I can speak from a leukemia care point of view, that things like our support groups are still running and things like that, and I can go through all that at the end. But also, we have a counselling fund that's open if you are looking for professional help as well. I think that's really important. And I don't know whether Claire as a CNS wants to talk a little bit about the mental health aspect as well. Slightly more qualified than me to talk about it in detail.
Claire Woodley?
think it's important to acknowledge these feelings that generally we're all having, the anxiety about being shielded, the anxiety about the lockdown easing and what that will then mean for us. And I think it's important to acknowledge these feelings and to actually recognise that actually it's okay to feel like that. There are lots of different ways that we can try and manage some of these feelings and to develop the skills and the tools at this current time to try and help us when perhaps our anxiety increases towards coming out of shielding. There are a lot of online apps that can be used for mindfulness, for dealing with thoughts. There's also relaxation. For some patients, exercise will help them deal with some of these feelings that they're experiencing as well. There was quite a good quote that I read about that we're all in the same storm, but we're all in a different boat. And I think that just kind of says that we all deal with this in different ways and that our perspectives are very different. So there's no one blanket guidance that will help everybody. And I think it's finding that balance of interventions that we find help us in this situation.
Thank you very much. So I'm conscious of time now, so we're coming up nearly to the hour, but we've got a couple of questions just to round up nicely about the future. So one of the questions is about, do we think telephone consultations will be a thing of the future? Adam?
Well, they were a thing of the past as well, so I'm sure they will continue to be used in the future. It may be, you know, I think that the rapidity of change in the context of the coronavirus outbreak has been something to behold, and I think there are some positive aspects to it, the way we've managed to adapt the service, and some aspects of that are definitely positive. But I think the degree to which a lot of the patient management is remote is unlikely to stay at that level, but I suspect this will provide an impetus to many centres increasing the amount of remote consultation that they do, but only when that's something that the patients also want to do and it is seen as mutually beneficial. I think the slight difference in this circumstance is, rather than this being a choice for the patient, it's almost been thrust upon everyone, patients and doctors alike, and that's the bit that I think we all feel a little bit uncomfortable about, but I think we can learn from some of the positives and take that forward as a kind of force for change in the future. So I think there will be some positive aspects in terms of how we run our clinics.
Thank you. And Charlotte, we've had a question about webinars itself. Do you see them carrying on?
Yeah, very much so. I think it's going to be difficult for many people to get together as groups for some time yet, regardless of the sort of the government announcements. It may also be sort of too worrying for people to get together. So indeed, we're looking at keeping these going. COVID specific ones, it depend on sort of whether there's any changes, and you can always look back at previous ones. We'll put them on YouTube and they'll be saved on MPN Voices Facebook page and also on ours. So there's a few places you can look for it to remind yourself of advice, and we will certainly be reaching out to our panelists here if we do feel like there is demand for another one. And please keep asking your questions, because that's sort of how we know whether there's something sort of worth making a webinar about.
Brilliant. Okay, before I pass back to Charlotte, I'm conscious that we maybe didn't get through all the questions, but as Charlotte said, we do have, by all means, we have different means that you can send your questions into, and you've got all the materials and places to go to get that information. So you've got MPN Voice webpage, Leukemia Care webpage, our Facebook page, and also at the end, Charlotte will be sharing some of the links for our advocacy and support side for you. So I'd just like to say, as I start to wrap up and pass back to Charlotte, thank you for all your questions. Hope you found them enjoyable, and thank you to the panel. And I will just pass back to Charlotte to finish up with the support side.
Thank you, Jo. So yeah, just a little bit more information on what's available from both MPN Voice and ourselves at Leukemia Care. So MPN Voice do a wide range of things. I have to say, I found their web page listing who should and shouldn't be shielding and advice around shielding particularly useful. So I have to personally thank them for that, and I would recommend their web page on that in particular. But of course, they provide plenty of support services, forums, buddy scheme, advocacy support, and the like. So I do encourage you to get in touch with them. They're very knowledgeable people. And also, again, from ourselves, very similar offering. Obviously, we cover a much wider range of blood cancer types, but we're doing these webinars, and we will continue to do them in collaboration with MPN Voice as and when necessary. We have newsletters, podcasts, social media, whatever format you're looking for information in, you can probably find it from us, so please get in touch. And then in terms of support services, obviously I mentioned a little bit about this earlier, but it's important to say that a lot of our support services are continuing in a digital form, including virtual support groups, welfare and advocacy advice we can do over the telephone, and obviously online forums, Facebook groups, and the like can all be done digitally. So please don't feel like you have to sort of sit out this period without any support whatsoever. And those there are our contact details. And if you don't quite catch them now, I would recommend going onto the YouTube or the Facebook page and just pausing them at the moment you need them, and then you can see them for future reference. It's also important to say there are other charities available in this particular context, Blood Cancer UK, you might find useful. And thank you to MPN Voice in particular for helping us recruit both speakers and participants for this webinar. We wouldn't have got quite such a response without them, so thank you very much for that. And I think that's all there is to say. I'd echo Joe's comments to the panelists. Thank you, Adam, Donal, Claire and Claire, for your time as ever. And thank you everyone for listening, and we'll see you next time. Thanks, guys.
Thank you.
Bye-bye.
Bye, thanks.
Bye.